Good afternoon, everyone. And welcome to today's ECHO presentation, where we'll be discussing one critical factor in reaching our 90-90-90, now 95-95-95, and that's the aspect of reaching men. And with me here is Dr. Ahmed, who is coming from CDC and will be our didactic presenter for the same topic. We'll have a case that is coming from, will be presented by Aaron Sukwa, who is sitting at Matero. So we hope that you'll be able to participate as usual. We've got a number of facilities which are joining us. And I think from here I can see about 13, and we expect more to join us. Please kindly let us know if you are not able to get us in terms of video or sound, but we ensure that we checked with all of us who have joined. So without much ado, we shall have a recap of last week's presentation, which was management of hepatitis B. Dr. Foloshi.
Hi, thank you so much, Dr. Mpeta. So last week we had Dr. Michael Vinica talking to us about hepatitis B surface antigen and hepatitis B disease. So some of the highlights are we need to monitor, once we have a patient who has hepatitis B surface antigen positive, it's important to note whether they're an adult or they're a child, because adults typically will actually clear the hepatitis B on their own spontaneously. However, you need to monitor the ALT. For women, we are looking at a maximum of 19, and for men, it's 13. The key is that it should be persistently elevated for more than 6 months for you to decide whether you are going to treat or not. Because withdrawing hepatitis B drugs can be very difficult, and remember, they also need to be monitored. And you'd rather wait for a person to clear the disease. As for children born to mothers who have hepatitis B, we need to give them the vaccine at birth. Remember, we give them the pentad at 6 weeks, but if mom has got hepatitis B, children will benefit from a vaccine at birth.
Okay, thank you very much, Dr. Foloshi. So we will go straight into the didactic, which will be presented by Dr. Ahmed. We'll definitely try to make it bigger.
Okay, good afternoon, everyone. My name is Ahmed Saadani, and I work with the CDC Zambia country office here in Lusaka, and I'm the clinical services team lead. So this is a great opportunity for me to be part of this process, and a great opportunity for me to participate in this discussion regarding men's access to HIV services, especially here in Zambia. So the idea of this presentation is not to provide you with something really new. Most of stakeholders, most of those who work on HIV at the site level, at the district or provincial level are aware basically of the main challenges, the barriers and the facilitators in terms of men's access to HIV services. But this is just a chance for us to reconvene and stir discussions, especially with those who work at the site level, in terms of how they see the challenges at their level and what they think could be the ideas that can be implemented practically at the site level in terms of allowing and facilitating access to HIV services by men. So the goal of this presentation consists of 3 objectives or goals. The first one is about understanding, getting an overview of the epidemiology and the data, what we know overall in terms of men-related programmatic data in Zambia specifically. The second objective consists of understanding what we know and what we perceive as facilitators and barriers to men's access to HIV services. And the third one is consists of recommendations, making recommendations and suggestions and strategies that are known or that prove to be effective in terms of facilitating access to HIV services by men. So starting by the first objective, in terms of data. So You know, Zambia took place 3 or 4 years ago. The results were the final results were published and known officially a few months ago. In terms of HIV status awareness, in terms of comparison by age and by sex, and you can see that men have less HIV awareness, a lower HIV awareness rate than when compared to females. So 69% compared to 62% based on Zambia. This is quite, this is becoming old data, but this is still relevant because this is the only data we have so far in terms of understanding the epidemic in Zambia, including that of men. The second point is just reflecting the fact that men aged between 15 and 19 have the lowest HIV awareness or testing rate coverage. So males have 27% as compared to females 45%. So the category of age between 15 and 19 has the lowest HIV testing coverage. The third one, just to show that also that coverage is also very low in the 25, 29 years old. This is a graph that shows the gap between males and females by category of age. The blue bar represents females and the green one represents males. And you can see, starting from the left-hand side, 15 to 19, up to the category of age 30 to 34, you can see the gap between the two bars at each category of age. You can see the gap between 15 and 34. Males tend to know less their HIV status than females. This is program data. This is coming from the data collected from sites from the program. This is PEPFAR's data based on the first quarter of the fiscal year, meaning October to December 2018 calendar year. This shows the modalities that account for most of the cases, the positive cases among men in PEPFAR's program. So we have VCT, what's called VCT. It includes different modalities, but overall, VCT accounts for 38% of the identified positives among men. PITC accounts for 35% of identified positives, and index testing represents 14% of identified positives. That's still low in terms of as an intervention. You know that we're pushing for index testing, but it's a progress compared to a year or 2 years ago in terms of the proportion of positives through the modality of index testing. This is a table that shows ART coverage in Zambia by age and by sex. This is overall, not by province. So this is all we can get so far in terms of ART coverage. It's just a higher level picture. We can't provide provincial data. We need to wait a couple of weeks before we have the final estimates that allow us to come up with ART coverage for men by province. But in the meantime, we can still rely on this data, and you can see that males aged 15 and above, or males in general, have a lower ART coverage nationwide as compared to other categories by age and by sex. So that's a discrepancy, a gap in terms of ART coverage. In terms of retention at 12 months is also lowest among men. The difference might not be very significant, but the fact of the matter is that it's lower in males as compared to females, and even overall, regardless of age. So that's also one aspect from the program. Data in terms of viral load suppression. Viral load suppression also, it's as low as females and as regardless of sex, but still you can see that viral load suppression is low across the categories of age up to 2024. So between 10 and 24 in males, viral load suppression is suboptimal. So the second goal consists of understanding known and perceived facilitators and barriers to men's access to HIV services. Now we are at the poll, question 1. So
So the first poll question is, the following statement is true, except most men have more opportunity for accessing HIV testing services. B, most men believe that HIV testing services are more inclined toward women. C, stigma prevents most men from accessing HIV testing services. Then D, index testing improves access of HIV testing by men. So we can now, sorry, this is the second poll. Okay, so we can give it a go. Only a third of us have polled. From the hub. Okay, so thank you very much for those of us who have participated. I don't know, maybe we'll come and run through the questions. We can go ahead with the presentation, then we'll come and discuss them.
Okay, we can go ahead. Sure, so the second objective of the presentation is to provide an overview, a summarized overview of facilitators, barriers, and strategies. In terms of facilitators, this is just a very this is a number of few facilitators based on what we know, the literature, surveys, studies, research, but mainly the next few slides use information coming from from data from programs in Zambia and other countries in the region. But recently there was a report that was published and presented officially showing the results of a study under the leadership conducted by USA Discover in terms of male characterization in DREAMS districts, a number of DREAMS districts. So that study showed very interesting aspects from which I picked some of the points here in the next few slides in terms of facilitators, barriers, and strategies. So in terms of facilitators, we have peer, no, you can go, yeah. So peer influence is a major one because we know that peers have a big influence on a man. Peers emerged as the primary source of health information and opinion that shapes individual health-seeking behavior. We have also family support. So men indicated that having supportive family members is important for service access and use. And they say that there are not many men who find it easy to disclose to family members, and therefore this facilitating factor is underutilized. We know also, based on that information, that persistent ill health and wanting to get better, that's one facilitator for men to seek services, and especially HIV-related services. In terms of barriers, so we have fear and apprehension. Fear and apprehension is a major one. Fear and apprehension emerge as a strong and pervasive barrier to HIV service uptake and utilization across service platforms and across users. And fear and apprehension delays service access until the problem is so serious that service access is no longer available. Another barrier is stigma and discrimination. stigma and discrimination, and health systems shutouts. So that includes a number of aspects. For example, negative health staff attitude. For example, negative staff attitude emerges as the most important barrier to both seeking services and to sustaining care for users, and as a key barrier to seeking services for non-users of HIV. Most of PLHIV indicate that they have experienced negative staff attitude, but that is not a deterrent to using and sustaining ART. Another barrier is related to gender and provider. And also men turn out to be interacting with the health system less frequently than women. The next slide, please. Okay, so can go through the.
Okay, so the second poll question, it's a bit lengthy, so we pay attention. So this is a 32-year-old pregnant woman who is in the second trimester and tests positive to HIV in the antenatal clinic and was initiated on antiretroviral treatment. She is requested to bring a partner for the next antenatal visit. On her next visit, she comes alone because the partner could not get a day off. When he knocks off, he normally passes through the local pool club to socialize with his friends. She failed to disclose her HIV status to him for fear of violence and abandonment. So, what workable innovations will likely get this partner into care? So, this is a woman, 32 years old, who presents in the second trimester for antenatal and tests HIV positive. She's requested to bring the partner for testing, but this doesn't work out because of the work schedule of the partner, who normally even passes through social places after work. The question is, what workable innovations will likely get this partner into care? Okay. We can go ahead and vote. Thank you. A third of us have already voted. The hub, people in the hub. Come and discuss this after.
So in terms of strategies, this is the third objective, is to suggest strategies that are being used or that have proved to be effective either in Zambia or other countries. So we saw that fear and apprehension is a major barrier. Addressing fear and apprehension is key. So increase male access to correct, consistent HIV information in order to assist men to better understand their health issues and to help them to make informed decisions, including informed health-seeking decisions and actions. The second strategy consists of making use of male champions and credible and relatable influencers such as role models and celebrities. Also ensuring closer proximity of clinical services to where men work and or congregate, and also in terms of strategies, decentralization of services is also one key aspect that can help decongest clinics, including drug dispensing and pharmacy outlets. Enhanced focus on confidentiality. We know that that's a major barrier, and especially using HIV self-testing, as we'll see in the next slide, some data about HIV self-testing, and for example, a use of self-testing in ANC settings, targeted community and facility testing, but especially and more importantly, index testing, assisted partner notification, also testing for partners and clients of female sex workers. Another set of strategies consist of differentiated service delivery, making sure services are offered conveniently to men and making it easier for men who work to get access to HIV services, for example, after hours and weekend facility-based testing, make site HIV clinics more male-friendly and offering more male-friendly services, integrating services in a way that there is less stigma, it's less stigmatizing for men to access services when we have integrated services, and also training of healthcare workers in ways on how to talk to men and offering patient-centered clinical services, male staff and sensitization of health workers, and improved clinic operations with easier booking systems and shorter waiting lists, waiting times. We mentioned HIV self-testing as a key intervention. We know data and findings from an initiative that was implemented a few years ago in a number of countries in the region, including Zambia. It started with 3 countries, and then it has been extended to 6 countries. The data from that approach, from the implementation of those activities aimed at implementing HIV self-testing kits in the community at the facility level. It shows, for example, from 6 countries that out of the total HIV self-testing kits that were distributed, about a third of them were among the 15-24 years, and about 60% were males, those who received those kits. That shows that it improves the access of men to testing. This is about first testers among those who use HIV self-testing kits that were distributed, and there you have the data from Zambia that shows that about 35% of the self-testing done was among the 15-24. These were first testers. These were individuals who tested for the first time. And this is just a table summarizing a number of models and the rationale of those models. This was presented last year at the PEPFAR annual meeting, giving a list of models and the rationale. You can see community-based distribution and the rationale of it, integration, enhanced index testing, male-dominated workplaces, transports, and integration with VMMC. This is a slide that just gives an overview of a few of the models that are implemented currently. This is what's ongoing in Zambia, the models that have been used by partners in terms of helping men's access to HIV services. So we have integrated male health clinics, for example, at Patero Hospital and Matero, Maine. We have distribution of HIV self-testing either in the community or at the facility. For example, at those 2 facilities and other facilities in Lusaka, there is a distribution of HIV self-test kits at the facility level, either for screening for those who are waiting for services, or in terms of the purpose will be also to decongest the facility by doing a sort of a pre-screening. Workplace outreach, this is being done by a number of partners using community posts, so for health HIV services at static points, for example, markets, and that's being done currently in Chawama and Kanyama. We have the Insaka meetings where there is a use of traditional leaders at the community level to provide advice to younger groups of men. And we have what's called the SARAI project, the Zambia Family Project, and Stop GBV project. And these are USAID-led models implemented in the community and the facility level to improve access to HIV services by men. So in summary, we can say that effective gender, the takeaway, effective gender-specific HIV stigma reduction initiatives are likely to improve male engagement in HIV services in general, and optimizing the design and implementation of differentiated service delivery models may also encourage more men to engage in HIV treatment, and providing diverse male-friendly services will be important also to fully engaging men in HIV response. And thank you very much.
Thank you very much, Dr. Ahmed, for that elaborate presentation on men's access to HIV services, barriers, strategies, and recommendations. And I think before we actually open up, we will go back to the 4 questions that we had. So the second poll, I think that we discussed about a 32-year-old woman who tested HIV positive in the second trimester at antenatal, and then she was asked to bring the partner. Relaunch, okay. All right, and was asked to bring the partner, of which the partner could not have the time because of the work schedule. So these are some of this is the question that we had. What workable innovations will likely get this partner into care? So we can give it a go after now. Yes, we can see. Okay, thank you very much. Any thoughts on that? So this is how we have done. About 67% have said all above. Then others, different percentages, have gone for the choices A to D. Any comment on that, Dr. John?
I would say the self-testing is very relevant. I think that's one intervention that proved, as we saw in the slides, very effective in terms of improving access and encouraging men to get tested, whether it's at the community or the facility level. I would say also index testing is very relevant. That's the most effective way to really find positives, whether they are men or not, and you're more likely to find a positive man by doing partner testing and index testing and tracking contacts, sexual contacts of women at the facility level, for example.
Define index testing.
So yeah, index testing. So when you find a positive, an individual with HIV infection at the facility level or community level, you try to elicit that positive in terms of finding sexual partners, sexual contacts, partners, husband, wife, but also going beyond the aspect of testing just the partner. So that's the idea of the index, is to make sure we have a very strong, robust counseling, quality counseling that makes sure that you can have the positive individual get you the names and the contacts of his or her sexual partners, and then get them tested also and get their results also. So that's, and you can do the same for any positive case that you find through that process of index testing. So it's beyond the partner notification and testing the conventional way of testing just the partner that had been used in many countries at the facility level.
Thank you very much. So within the hub, we've got also Lina Mwango, who is coming from DCOP Circuit Project. Would you just maybe give us your thoughts about this and with regards to the second question that we're discussing?
Okay, so thank you very much. I actually work on a project that's targeting priority and key populations. And mainly under the priority populations, we're targeting men who are the partners to the adolescent girls and the young women. So the main modalities that we're using to find these men are mainly through index testing, because majority of our patients that are on treatment, on ART treatment, most of them are female clients. So through these female clients, we're able to do elicitations, and then we're able to elicit male contacts. And the other strategy that we're using is a social network testing, where we identify men who are in high-risk behaviors, and they also bring their fellow team members from the same high-risk groups, and then we're able to follow them in the community. So really the project that I work on is basically community-based intervention for HIV prevention as well as treatment. For those that are hard to link to treatment, we're actually doing community initiation. So where we follow them in the community and initiate them and continue monitoring and make sure that at one point, whenever they are free, especially over the weekend, we bring them over to the facilities.
So all of these above choices are likely going to...
Yes, so we use the female clients to do a secondary distribution to their partners. We also do community testing, so following them, mainly venue-based testing for those who are very busy, like in construction companies. We also do household tastings. We follow them in their house. So all those interventions are actually ideal to reach out to men.
All right, thank you very much. So let's look at the first poll question. So the following statement is true, except most men have opportunity for accessing HIV testing services. Then B, most men believe that HIV testing services are more inclined toward women. C, stigma prevents most men from accessing HIV testing services. And D, index testing improved access to HIV testing by men. So we can give it a go. So we can see that at least about just 15% there have gone for A. So we are saying all of these are true except one. One is false. So which one is that which is false? Dr. Ahmed?
So I would say most men have more opportunity for accessing HTS. That's, in my opinion, based on what we know in terms of acceptability, in terms of where men are and their seeking behavior and their knowledge and the fear, the stigma, the apprehension, and the beliefs they have in terms of services that are offered to them at the facility, their, the way they think of the health system in terms of the way it's based on what they believe, it's more inclined toward women. I would say it's the first that you need to exclude, because I know that index testing, for example, improves access to HTS by men, and stigma, as we saw earlier, prevents men from accessing HTS. That's a key barrier to accessing to case finding among men in general. And we know also that most men believe that HTS are more inclined toward women, and that's something, that's a finding also from the study I mentioned earlier, the reports from the study conducted by Discover in the DREAMS districts.
Okay, so thank you very much. We have seen actually quite an improvement in this. The statement that is false, as discussed, is the first one. Most men have more opportunity for accessing HIV testing services. We will now invite contributions or questions from the network. So feel free to ask any questions before we go to the case presentation. Can I see a hand? Okay, HW21, we've seen the hand there, although they were supposed to. Yes, go ahead.
Yes, thank you very much for the presentation. It was very informative. My question is on the issue of gender. one aspect that is preventing or a barrier to the men to get HIV testing was stated to be the gender issue among healthcare providers. Does it imply that which one is more affected? Is it those that are tested by the females or those that are tested by their fellow men? Which ones of the two do the male clients accept most?
Yeah, so what I meant, and sorry if it was not clear, what comes out of the studies and the surveys that have been done is that men are more likely to be willing to test for HIV if it's a male provider who is taking care of that. So they're less likely to test if it's a female health worker who is providing that service in general.
Okay, so meaning males are more inclined or are likely going to access the service if it's a female. Any other clarifications or comments we may have from the network? As we are waiting for more clarifications, I think maybe, Lena, you may provide any of the insights on what we have discussed so far. And please, Aaron, kindly be on standby to share your slides for the case.
Okay, so generally men are busy, and I think looking at especially our healthcare system, our setups really are not men friendly, and that's how come most of our men really take long to access healthcare services. So really tailoring the way healthcare services are being delivered. I know for a woman, we have specifically maternal and child health services, which are basically focusing more on women, but rarely do we have male-specific healthcare services where men can even access when they are not in bad health. So for us women, we go through maternal and child services and get various support, even as we are maybe prenatal as well as postnatal. So it's basically making our healthcare services more friendly and have our men actively participate in healthcare services and really just also engaging them. I know most of the community, like at community level, when you look at the community health workers, you find mainly the volunteers are females. And maybe sometimes no males are being involved. So I think we need to do some advocacy as well as community sensitizations to make sure that also men are involved and take active role in participating in the health of the community.
Thank you very much. So before we go, Aaron, did I miss any hand? HW21 again. All right, thank you very much.
Is it possible for us, for the child, we have national immunization days for children. Could it be possible for us to come up with a day in a year where we just promote male HIV testing, where we have services available all over the community, where males are given that chance to go for testing?
Any thoughts, Lina? Dr. Ahmed?
Yeah, I think so. I think that would be ideal. But however, most of our men are more inclined to taking care of the family and really looking for food for the family. So maybe taking these services closer or taking them where they are, where these men are found, I think that would be more ideal. And I think we have Women's Day, we have Youth Day, but we don't have a day that's really for men where we can just find men.
Yeah, just to add, maybe, emphasize the fact that something that's key to encouraging men to seek services, HIV services, is making clinics more male-friendly and sensitize the staff in terms of how what men want and how convenient services they need.
So thank you very much. We now move into our case presentation. So we shall invite Aaron, who I can see is very much ready to share the case. Aaron, are you ready?
Yes. Good afternoon. My name is Aaron. I'm a district TB HIV clinic manager. So the case we're having today is from Matero. We're looking at a male client, aged 45. He's a migrant worker, resident in Matero. Client tested HIV positive and started ART in April 2017. On the day of initiation, he was WHO stage 3. He had chronic diarrhea, which has not resolved up to date. He was also treated for pulmonary TB in April 2017, and he completed the 6 months of ATT. He's a high-risk heterosexual with multiple unprotected sexual relationships. He's said to have been adherent to his ARVs. He now complains of sore throat, difficulties in swallowing solid food for 9 months. Then there's loss of weight greater than 10%. Then he also has genital warts for 6 months now and diarrhea for more than 1 month. On physical examination at his last visit, he was wasted but stable. He had esophageal thrush, chest clinically clear, no abnormalities on examination of the abdomen, and then he also presented with genital warts. The vitals are as follows. His weight was 55 kg, height 179 centimeters, BMI 17 kg per meter squared. Temperature was 35.2 degrees, respiratory rate was 20, his BP was 108 over 67, his pulse was 98 beats per minute. His medication summary is as follows. He was initiated on TDF, TTC, and EFV on the 18th of April, 2017. His clinical condition was worsening from stage 3 to stage 4 as the diarrhea is not resolving. He was switched to SZT3TC and atazanava on the 21st of March, 2019. Other drugs that he's currently taking are Septrin, fluconazole, albendazole, and amoxicillin. His lab results are as follows. On the 27th of March 2017, his CD4 was 69, his HB was 14.2. Then on the 20th of September 2018, his viral load was 87,430. They, however, tried to repeat the viral load on 7th February, but the sample, unfortunately, the sample that was collected was not sufficient. Then on the 21st of March 2019, they collected blood for CD4, HP, and viral load. We only managed to get back the HP results. We're still waiting for the CD4 and viral load results. Other tests that were done that we're waiting for results include AST, ALT, full blood count, creatinine, stool, and others, sputum for gene expert, chest x-ray, and he also needs to do a urine lung. So our questions are as follows. The first one is switching to second line for failure due to factors other than adherence a correct thing to do? And the second one is, can this patient benefit from the genotype resistance testing? That ends the presentation.
All right, thank you very much, Aaron. And I think before we look more on the clinical aspect, let's look more of at a program kind of view, especially that we are talking about men's HIV services. How could we, or what services could be available for this man? This is a 45-year-old man who tested HIV positive, has been having a lot of treatment issues. He's unsuppressed, he's got advanced HIV, and we find that he's a very high risk, heterosexual, and he reports not having protected sex. What sort of services could be available for this man? Dr. Ahmed and Lina, any thoughts before we go to more of clinical aspects?
What prevention services can we offer?
For this gentleman, yes.
If somebody wants to.
Sorry?
There's somebody who wants to talk.
So maybe I should summarize the case. So we have a gentleman who's a migrant worker. I believe he's a truck driver.
Yes.
Moves around started off at a very low CD4 of about 69, put on TLE, seems to have had this diarrhea, not very well, right now has even genital warts. Unfortunately, he still has this high-risk sexual behavior. I think Dr. Mpecha is asking, well, we have this migrant who's a male. How did we get here? What could we have done better? Because I know when I went to Kafue maybe 6 months ago, I was told they have all these truck drivers that come, they pick up medication for a week. Then they go, they never come back. They go to another place, they pick up a week. But I know in our health system, we have rules, isn't it? We say, we need your card. You need to give us a DMD number before we can give you drugs. So he's asking, how could we have done better? You know, because obviously he's due for the index testing. He's been spreading the virus. His viral load is in the 89,000. So I think the question is, how could we, what type of services can we give people who fall in this category, men who are mobile?
Yeah, so I think exactly what's really critical for the mobile population is deploying preventive measures even before we reached where we've reached. So one of the key strategies right now, and I think everyone knows, we have PrEP in Zambia. So really we need to start discussing PrEP mainly with the mobile populations, making sure that PrEP is very accessible to everyone that needs it. So the migrant workers fall under key populations. And I think right now PrEP is available but not very accessible, especially that it's being provided in ART clinics. So there's that stigma attached to it. As well, the other thing that we need to do is focusing on the priority population prevention. So VMMC, making condoms readily available. I think one of the other things that we do is community distribution of these condoms and really just following these migrant populations where they are found and providing these services in a differentiated service delivery model and really making the same rules that we have around ART, because sometimes they move around and they don't know when they are going to come back. So say, for example, they're in Kasumbalesa and they've run out of drugs. We'll only tell them that we can only give you for 2 weeks, but then it will take them maybe 3-4 months to get back to their ART facility. So it's really being flexible within our systems and making our systems more accommodative. And I think really, as an advocate for differentiated service delivery models, we really need to scale up DSD to meet each client's needs.
All right. Thank you very much. I saw a hand from HW21. Annie
Yes.
from HW21.
I'm Lucy Zulu.
Okay.
Yes.
Sorry about that.
I think we need to still continue intensifying the counseling services where the mobile populations are found. We seem to have relaxed in terms of the IC materials that we need to give to them, and even the programs like radio programs where they switch on to the radio as they drive. They could be listening to some talks on HIV. We seem to be relaxing in terms of the counseling sessions and also provision of IEC materials.
Thank you very much. Did you have any thoughts, Dr.?
I think Lena summarized very well.
Okay, thank you very much. One of as we are waiting for people to contribute, one of the thoughts is, why is it that men are not really regarded as a key population? Why can't we just declare all men as a key population?
Priority. They fall under priority population.
Why not key? Because we have seen that's where we have got most of the issues.
What's the difference?
What's the difference? Maybe we missed.
So the key populations are the ones at substantial risk. The risk is different. For the priority population, say for example, there are some men who probably just find themselves in risk behaviors because of certain situations, being away from home maybe for a month or so, we end up engaging in other risk behaviors. But for key populations, the risk is much, much higher because, I mean, that's the way they are and that's their lifestyle. So men are priority populations. We prioritize them anyway.
Thank you very much. Yeah.
I mean, I had a question for those who work at the site level, who manage programs and implement activities. I was wondering if there are any examples of teams at the site level who look at the data at their sites and come up with the information related to coverage, to access, to case finding. And are they looking at those groups of the population specifically at their sites? Are they looking at ways to improve access to men, for example, among other groups? And what are they doing about that? Because when you look at every, I mean, almost all sites nationwide, it's the same problem of access of men to HIV services, whether it's about case finding or initiation of ARVs or retention on ARVs, viral load suppression. What sites are they doing about the specific group of men, especially younger men between 15 to 34? Are there any examples that can be shared?
So this actually goes now to the whole network, not any particular site. Is there any sites that has got, stats about this type of men who are in a migrant population, and what programs have we put in place in trying to deliberately reach to them? So any of us in the network can actually take it up and share your experiences.
I will ask, for example, among those who are on the call, how many have weekend clinics and after-hours clinics, and how many are providing self-testing kits at the facility level or at the community level? How many have male clinics, for example, specific clinics for males? How many have integrated clinics, including HIV services and non-HIV services, in a way that we reduce stigma, for example, that's related to access of men to HIV services? So are there any aspects like this that are implemented concretely at the site level? And did you see any change? Did you see any improvements since you started your activities? For example, at the clinic, you have a male-friendly clinic. Did you see any change over the time?
Mongo Aban, I can see your hand. Please share with us your experiences. Yes, Mongo Aban, you can make your contribution.
Yes, so I was just moving closer to the mic. For Mongo district, we have had a program to do with the key population, because we have thought about it, that mostly the sex workers are key in helping us reach to the men. So we've held meetings with them, and at least we have established baseline, like for Mongo district to start with, so that we are able to reach the men in terms of distribution of condoms, and also encouraging those that are testing negative to at least access PrEP, so that the transmission rates can at least reduce. So at least we have seen a decline in transmission rates, because we are able to test more and also get more positives, and also initiate more on PrEP for those that are testing negative. And also for the after hours clinics, they are also bringing more men, because like for urban clinic, we are implementing that. Like for last month, we are implementing the after hours clinics, which are improving the attendance of the men and getting more positives on the men side. So we could have shared our data. It's only that right now it's not ready, but it has really improved in terms of the after hours, and also the key population meetings held.
Okay, so thank you. Maybe before you sit, what are your after hours like? Would you just quickly tell us what this flexibility is?
Our after hours, we are engaging a community-based volunteer who is a counselor and a nurse who works a night duty like the other staff would work. So we have included them on a schedule like the other workers who come just for general, maybe outpatient department. Then they'll do the testing, and in case someone is tested positive, of course, the testing is done with the use of a screening tool. So when one is tested positive, the nurse who is attending to the after hours is able to initiate treatment on that person who tests positive. Then a day after or the following morning, the counselor is able to follow up on the indexes that are elicited from that positive client.
Okay, thank you very much. So, Nyimba, I've seen your hand is up. Please come through.
Good morning.
Good afternoon.
Yeah, Dr. Kavala Koli talking. Yeah, I'll give the experience that we are having from Petauke, but I'm following the echo from Nyimba.
Okay.
In Petauke, we are having after hours. We go out with vehicle volunteers and clinicians, and we target hotspots where we screen clients and we test them. Those are positive, we link them immediately to treatment, and education is done immediately. That's what we are doing for after hours in Petauke. But we have been having other services for key population, like we have been having meetings with female sexual workers. We meet them, we offer drinks, and we test them after counseling. And then those are positive, we link them to treatment. Those are negative, they go into bed. We are targeting other group of population like taxi drivers. We are planning to meet with them according to their categories.
So thank you very much. That's Nyimba or Petauke data being shared. St. Francis. St. Francis, you had your hand up.
Yes, I'm calling from St. Yes. I'm on a from St. Francis for truck drivers. We give 6 months supply, then we request them to come for CD4 count at viral loads.
Sorry, come again about the CD4 and the viral load.
I'm saying for truck drivers, we give 6 months supply, then we request them to come for viral load and CD4 counts. If they're going out of this.
So basically, you try to find out if they'll be out from the district for some time. Then you give them supplies for that period. Is that correct?
Yes.
All right. Thank you very much. I haven't seen another hand, so I don't know. Maybe Dr. Ahmed, you want to
I just wanted
innovations in this facilities?
Yeah, I just wanted to add that. We're talking about specific interventions that are targeting men, and but we need to remember that also basic interventions that we are advocating for, we're trying to implement and scale up at all sites, at least at high volume sites, is DSD, differentiated service delivery for everyone who is stable. So that goes through viral load coverage, because that's a prerequisite to enroll someone who is stable. That's the definition of stable patients, includes viral load suppression. So you need to increase your coverage for routine viral load testing among your patients who are on ERVs, so you can enroll them in differentiated service delivery and provide them with at least 6 months ARVs, which is now national policy. And that's a differentiated service delivery that can help encourage men seek services also, and make them less adherent to their treatments. So by scaling up DSD models at high volume sites, you decongest sites, you reduce waiting time, and you encourage men to seek services at the facility level, because these are some of the barriers that are preventing men from seeking services at the facility level. So if you have facilities that are male-friendly in terms of waiting time, reducing waiting time, in terms of providing enough ARVs for those who are stable, that's something that can improve access of men to HIV services in general. So that goes indirectly through viral load coverage and also scale up of DSD models at the site level, and especially multi-month scripts for ARVs.
So thank you very much, Dr. Ahmed. So I think we have got just a few minutes remaining. Maybe Dr. Sombo, on the clinical aspect, the last two questions. There was one about is switching to second line for failure due to other factors other than adherence a correct thing to do?
Oh, well, I wasn't expecting that, but definitely I do it all the time in my practice, because sometimes you have to look at the urgency. Now I have to go back to the case. I think the gentleman started treatment in 2017. Of course, the most important thing is to make sure he's adherent to his current treatment. And we really need to bear in mind when we are switching people to second line, if there is concurrent TB, the regime becomes very complex. So switching to second line is not one of those things you do automatically. Remember, our first line is actually one of the best. It's supposed to be very, very effective. Especially now that we have TLD, if you see a patient like this from 2017, they are not doing well on TLD, it's likely due to the adherence. But you note that he started off at a very low CD4 count and has diarrhea. So I would be concerned about issues of malabsorption. Has he been absorbing this drug adequately? Is that contributing to his failure? Has he been coming to the clinic around 17 and we are telling him the clinic is closed? So changing second line may not be very helpful in these patients. However, there are many reasons we can switch to a second line that may not be what we recommend in the guidelines. For example, I think the question from Aaron is the patient has only one viral load, but on the background of that, you have a very low CD4 count that gives you an idea what was happening that far back. So you may not need 3 viral loads. So sometimes we change because of toxicity. If there's toxicity to tenofovir, we may have to use other drugs. If there's toxicity to efavirenz, we may have to move to a second line. So it's not always adherence, but of course it's always good to stick to the guidelines. They're evidence-based, but unfortunately patients don't read the guidelines, and patients would come in like that. So we would prioritize adherence, get further history. Also, is this patient likely to come back to our clinic if we keep him on TLE? What is his risk of mortality? Remember, our mortality is 10 times more than that. Actually, this patient qualifies for a DSD model called the unstable patients. These are patients who are at high risk of mortality, and he is one of them. So my eye would be on the ball with this guy. I would want to give him very effective ART, but that depends on a lot of things that may be nuanced, that require you to interact with the patient. To think a patient has a CD4 of 69 and chronic diarrhea and has been cancelled appropriately to take his ART, I would probably switch this client, but my eye would be on the ball. This is not a guy I would give 6 months of ART. This guy qualifies for patients at high risk of progression. So it qualifies to go into a DSD model for unstable client. So we need to be more precise with him. I'm sure you noticed they talked about a urine lamp. You can do a chest x-ray. He needs to be screened for TB. What's going on? Why is he at this CD for 3 years into, only 2 to 3 years into ART? So
yeah, just to, if I can add, I mean, so this is a man, and we know men are more likely, they tend to test only when they go for testing only when they get very sick and get their CD4 very low. So that's a typical case of a man who got tested with a very low CD4. But what should have been done at the time is to appropriately rule out any opportunistic infection. This is a very likely situation where the patient was on ARVs while having an opportunistic infection such as TB or something else. And the tests that were requested a year later or 2 years later are a bit too late, because that was the type of test that should have been requested when he was first enrolled in HIV care. So that just something to emphasize. When you have a very low CD4, you need to really do everything to rule out opportunistic infection before you start ARVs.
Okay, so thank you. Just to complete the questions from Aaron and Tim, this is a patient on first-line chronic diarrhea and virologically failing. They wanted to find out, is a genotype necessary in this patient? Is the patient going to benefit from a genotype?
The simple answer is no. 2 reasons. A genotype takes very long. It can even take as long as 6 months because of health systems. At UTH, the earliest, if we really push, is 6 weeks. So I need to ask myself, should I wait 6 weeks for this guy with diarrhea who has genital warts for him to get better? I think not. We know his exposure is TLE. So we know he hasn't been exposed to AZT. The mutations you get from TDF at the K65R, they should not impact your AZT that much. For the PIs, your PIs would be the difficult ones. He's not PI exposed, and PIs are very good ARTs. However, he has diarrhea. So lopinivir, we know the side effects is diarrhea. So in my practice, I have the option of using lopinivir or atazanavir. We know we can't use atazanavir in people with HIV-2. It's not effective. But we also know that only a small population has HIV-2. So I'd go ahead and switch him to AZT, 3TC, and atazanavir. If I wish, I can even retest to check for HIV-2, because also adherence is very important. Remember, lopinivir, you have to take a lot of tablets on it. So generally, you don't want to give someone who has failed to take 1 tablet, 6 tablets. So if you went to AZT, 3TC, and ataz, that's 3 tablets a day, which is much, much better.
Thank you very much, Dr. Foloshi, for that. Aaron and team, I think we'd like to get back to you now. I don't know, were those discussions helpful? Did we get anything about how we can assist in retaining this patient into care? Especially this is a patient who is at risk of progression and mortality. And then about the issues of switching to second line and the genotype. Aaron?
Yes, the contributions have been very helpful. And from here, we'll take up the care, but we'd also like to clarify, is it okay for us to go ahead and retest this client to find out if they might have HIV too?
Absolutely, yeah, that would be quite essential, because we could be having, somebody who is unsuppressed because of HIV too, especially that they were on first line, which contains efavirenz and quite not effective. So, any other?
Any other questions?
Or clarifications before we end?
No. Thank you very much for the...
Okay, so thank you very much, Aaron and team, for that wonderful case, which was actually trying to make us emphasize men's access to HIV services. And I would also like to thank Dr. Ahmed and Madam Wango for coming over to assist us in the discussion of this topic, as we know that the epidemics which were shown about men are quite, disappointing in as far as the HIV control is concerned. So we all owe it to ourselves to ensure that we put in more effort in trying to ensure that more men actually access HIV services and they are into care. So next week, we will be discussing
approach to patients failing second line. They're people that really need genotypes because they're also pricey. They're not cheap.
Yeah, so thank you for that. And this will be presented by Dr. Ile. He will be talking about approaches to patients failing second line. And I think we know that we've got quite a number of patients who are failing second line, and most of us are confused of what to do with these patients. So please stay. There's a hand. Unless it's pertinent, let's give them a chance, but we're about to close. Kindly please unmute them. I don't have them. Maramba,
Hello,
we have seen that you're coming with a late entry question.
Hello, good afternoon.
Good afternoon.
Dr. Banda here, Maramba Clinic, Livingston. Sorry for taking you a little bit backwards. We just wanted to clarify. We noticed that this patient was put on AZT 3TC atazanavir, which I think Dr. Sombo was talking about since 2018. And I didn't get the treatment that this patient should continue on. So
sorry, you didn't get the what?
The treatment that the patient will continue on, because this patient has been on AZT 3TC atazanavir, if I got it correctly, since 2018. and still had a high viral load.
It was 3 weeks ago.
Oh, this was actually 2 weeks ago. 2 weeks ago. Yeah. So this is so this is a new treatment.
Oh, all right. Okay. Thank you.
All right. Okay. Okay. Thanks. All right. So thank you very much. We would like to thank everyone who has joined from the network individually and collectively as a center or facility. Until next week, goodbye from all of us.
Yeah, and before everyone drops off, thank you so much for participating. This is NOMSA. I'm always communicating to most of you. We want to just continue to remind the facilities that you send your registers as soon as you drop off from the network. And please remember, this is also value to your career. We attribute your participation to continued professional development, and we need the registrars as part of the verification that you are participating. So I hope that the facilities that have participated, including individuals, please send through your names as soon as you drop off from this network. Thank you. See you next Monday as we look at the next topic, an exciting topic, approach to patients failing the second line regime. Thank you so much.
Thank you.